This is a lecture by Alemi on how to design an electronic health record that leads to process improvement. This lecture is narrated by Jonathan Duxbury. When it comes to electronic health records, we want a system that improves operations and does not perpetuate old habits. We want to focus on the future and not what has been. We want to design the electronic health record system to meet the needs of a diverse group of employees and not just a few leaders. Leaders come and go, but the frontline employees who have to use the system day in and day out are here to stay. Electronic health records should meet the needs of these frontline employees. We begin by examining how clinicians decide about patient care. If we are going to have an impact on the quality of care, these decisions need to be improved. Unfortunately, clinicians say they need information that they may not use. So in designing information systems, we need to follow a procedure that helps focus the effort on needs of clinicians and not their wish list. But what is it that clinicians need, and how would the electronic health record meet these needs? Electronic health records are costly investments. Effective managers will make sure that these systems enable the organization to achieve its objectives. To help managers design and shape an information system that meets upcoming needs of the organization, we have put together a planning process. This process starts with specifying the business objective of the electronic health records. Then, several use cases are developed to see how the electronic health record changes the work process. A use case is a description of interaction between the system and the electronic health record. A use case focuses on a specific clinical decision. Then the information needed in this decision is examined and the role of the system in meeting these needs is clarified. The design of the electronic health record is complete when a large number of use cases are reviewed and the way the information system will meet the need of the clinicians is clarified. In essence, the process we are recommending to you is to make sure that the electronic health record succeeds in bringing about improvements because you planned it to succeed. Many organizations look at electronic health records as a method of storing and retrieving data. They ignore the potential of these systems to change work processes. This is a waste of their investment. When you do not plan for change, it is unlikely to occur. The claims that electronic health records would lead to improvement often are not materialized. We recommend to you to design new work processes that go hand in hand with a new electronic health record. We want you to bring process improvement considerations directly to specification of system requirements for an electronic health record. The take-home lesson is simple. Real improvements need planning. Improvement that is not imagined is unlikely to occur. Earlier we presented a procedure for designing process improvement into use of electronic health records. This lecture supplements the earlier lecture with an example. We were asked to design an electronic health record for a Northeastern HMO. The business case for this investment was made on the grounds that the new system will reduce the number of unnecessary visits and thus make the clinicians more effective. First, let us provide some background information. This was a staff model, thus an unnecessary visit avoided was important to financial success of the organization. Second, both patients and providers were assumed to have access to email and the internet. Third, it was assumed that the informed consumer would want to take care of their own health. Of course, what we were designing was not for every patient, and a percent of the patients would have preferred to come in and have a visit even when they knew that the visit was not necessary. Our charge was to design electronic health records so that we could avoid unnecessary visits for a segment of the patients who were willing to communicate with their clinician online. The first step was to develop use cases for primary care visits. To accomplish this, we looked at the studies of primary care that had described the content of these visits. The most common reason for a visit was the yearly general medical exam, the so-called well exam. The second reason for visits was for acute upper respiratory infections. The third most common reason for visits to primary care was for prenatal and postnatal care. The fourth reason was for management of hypertension, and so on. The least common reason for the visit was the malignant neoplasm of the skin. Data showed that 63 cluster of diseases would explain 80% of visits to primary care. Therefore, we started our design effort by creating use cases for these. For each cluster, we created a use case. We described a scenario of how the electronic health record would help the clinician avoid an unnecessary visit. We created the scenarios by asking internal and external experts to clarify the potential impact of the electronic health record. They would trace the decision that needed to be made and examine if the necessary information would be available through the electronic health record in time for the decision. For general medical exams, the panel of experts felt that patients should visit the lab before the scheduled appointment. They would complete a health risk assessment online prior to coming in for a visit. The computer would guide the patient in conducting self-examination before the clinical examination. And the computer would help the patient plan for the visit by listing questions they want to ask their clinicians during the visit. The panel of the experts then clarified what % of patients would take advantage of these features and what would be the potential impact on productivity. In their view, these steps would reduce the time for a well visit from a typical 1 hour to half an hour for 70% of the HMO's members. Given this use case, the analyst would specify the information and functionality needed to carry out the planned new process. Let's look at the plans again. Obviously, we would need a comprehensive online risk appraisal system that is easy to use by the patient. The system would need to know if the patient had indeed followed the instructions and conducted self-examination and what findings the patient has had. The system would need to have a place to record the patient's questions so that they can be retrieved at the visit and addressed. Those information items are then added to our requirement list. Then another use case is examined. The next use case focused on acute upper respiratory infection. Here the new process starts with a phone or email contact requesting a visit. Clinicians review the symptoms and watch a patient carefully to see if the symptoms get worse over time. The system would follow the patient automatically to check on recovery. The experts estimated the impact of this new process of carefully watching patients in the community. Experts believe that in 60% of cases, the patient would get better in time and the initial visit could have been saved. If this process is successfully implemented, the electronic health record needs a specific set of data. Obviously, we need to record patient symptoms at the time of making the appointment. We also need to track these symptoms in time. We need to make sure the system can call the patient and see if symptoms have gotten worse. We added the information needed to our list of requirements, then moved on to examine other use cases. For hypertension, the panel thought that a visit could be avoided if patients could assess their own blood pressure at home. Then the patient calls the blood pressure in, or the computer calls the patient and gets the information. Clinicians would be available by email to change prescription, examine progress of the patient, and answer their questions. The panel estimated the potential impact of the new process to reduce visits among 70% of patients with hypertension. Obviously, one should consider the added cost of giving blood pressure monitoring equipment to the patients. The information required for this new process can now be clarified. First, the blood pressure at home must be recorded. Side effects of the medication should be clarified. Change in blood pressure should be analyzed and clinician alerted. These were added to the requirement list. As more use cases are examined, more information items are added to the required information list. When the list is complete, the planned process improvements have been integrated with the planned information system. This approach shows you how to design information systems that derive their specification from process improvement efforts. This approach helps organizations plan for upcoming changes and to build a new clinical process into their systems. The take-home lesson is simple. Real improvements need planning. Improvement that is not imagined is unlikely to occur.